Many ophthalmologists and retina specialists ask what is the next future treating wet AMD. And we had a lot of expectations on potential combinations, such as Fovista combined with anti-VEGF therapy. The phase 2 results were very promising, very outstanding, taking the level of benefit far behind because of preventing fibrosis or because enhancing the effect of anti-VEGF. Very unfortunately, phase 3 results did not show a difference between the combination and the monoarm therapy, anti-VEGF therapy. And it was not because the combination failed, it was because the control group did very well. So probably there was some undetected differences in the entry criteria of the patients. Maybe those patients were more likely to gain vision by anti-VEGF therapy for any reason. But the end result was that the phase 3 did not show significant difference between combination and monotherapy. So unfortunately, we cannot rely on that potential advantage for the future. However, before thinking in new therapies and new approaches and so on, everyone should ask themselves, are you using properly the injections we have right now? Because unfortunately, the numbers of real-world use in different countries, in different practices, it's quite disappointing. The mean number of injections per year is pretty low in countries such as Germany, France, Spain, Italy. And this translates into worse outcomes, not comparable to the clinical trials outcomes. And those countries that use more injections, like UK or Australia, they have better outcomes. There is no trick, more injections, more visual acuity. So reactive regimens, real-world practice makes that in many situations patients are not well undertreated. They're not well treated, they're undertreated, and we don't have the outcomes we could have if we were using what we already have more properly. So ophthalmology and retina specialists should reconsider their practices and their protocols, and they should consider if they should not be doing more proactive regimens, prioritizing injections more than visits, such as with a treat and extend regimen, because at the end, more number of injections means more vision. And it's well published, and it's an illusion that by sparing injections with PRN regimens, at the end, those patients have not good enough outcomes. So before asking for future developments, we should better use what we already have.